to the
This
demo.
was really good. How do you get really good at performing a TE? I think there's two things you have to know. The first, do a lot of studies. You need a lot of practical experience. And the second, you have to see many pathologies. And believe me, there are many, many pathologies to see. And in this chapter, I'm going to show you some of them to help you increase your caseload. What about this patient here? We can see in the four-chamber view, which is, I guess, turned a little bit to the right ventricle, that we have a rather thick structure right here. This is also visible in the bicaval view. Here we have the SVC. This is the intraatrial septum. And right here we have this huge tumor. What is it? Well, nothing to worry about. It's something that you can find relatively frequently, especially in obese patients. It's what we call lipomatous hypertrophy of the intraatrial septum. Here's another example. Bicaval view, SVC, intraatrial septum. This is the premium part of the septum, and the secundum atrial septum is very, very thick and dense. Another structure you should not worry about is the Eustachian valve, which sometimes can be rather prominent. It arises here from the entry site of the IVC and can be rather long. This is definitely not a vegetation or a tumor. It's a normal structure. What about this here? Well, this definitely is also the Eustachian valve, but something is attached to the Eustachian valve. So we can even have vegetation sometimes, as in this case, on the Eustachian valve. So look closely. What about the structure right here? Well, this is the left atrial appendage here, and then we have this structure right here, which mimics a left atrial thrombus. It is not a thrombus. What we have here is a reverberation from the limbus. The limbus divides the left atrial appendage from the left upper pulmonary vein, and this reverberation from this part of the limbus reflects right down here and appears or mimics a thrombus. Nothing to worry about. So, what is the key message here? First of all, beware that not everything that looks like a pathology is really pathology. Learn anatomy and learn where the pitfalls are if you perform TE. Are you now ready to look at left ventricle function with the help of TE? How would you grade left ventricle function here? Transgastric short axis view. The left ventricle is definitely dilated, and I guess all of you will correctly quantify left ventricle function as reduced. What about this example here? The ventricle is definitely smaller, and ventricle function is normal. A last example, this is a patient who definitely has hyperdynamic left ventricle function and also a small pericardial effusion, as you can see. What about right ventricle function? Take a look at this short axis view. The right ventricle is seen right here, and definitely right ventricle function is impaired. Probably also left ventricle dysfunction is present. Is that what we see on this image? Well, there's more to it. If you use color Doppler, we see that there is a communication between the left ventricle and the right ventricle. What we have here is an ischemic ventricular septal defect, a very important diagnosis in the setting of acute myocardial infarction because this patient urgently needs surgery. What is the problem here? A four-chamber view. The left ventricle looks okay, but the right ventricle is dilated and right ventricular function is poor. That is his main problem, a patient who had isolated myocarditis as we think of the right ventricle. And then, when we perform TE, don't forget we should also look outside the heart. As with transthoracic echo, there's more to echocardiography than the heart itself. And pleural effusion is a common finding, especially on intensive care units, and we can detect it with TE. Of course, we do not need to perform a TE to see the pericardial effusion, but if you do see it, it is quite helpful. Now, where do you think this effusion is? Is it on the left side or on the right side? Well, there's a little trick, the so-called tiger claw sign. If you imagine that the pericardial effusion usually has the shape of such a tiger claw, then the tip of this tiger claw on the image screen points to the direction where the effusion is. If it points to the right, the effusion is on the right. If it points to the left, on the left. Then we see different characteristics of pleural effusions as well. Here is pericardial effusion where we have fibrous strands and organized material inside the pleural effusion, which basically means that it's probably of infective origin. What do these three short axis views of the aorta have in common? All three patients have a congenital abnormal aortic valve. And all three actually have a so-called raphe, which means there's a fusion between two cusps. However, the morphology looks a little bit different in all of these three cases. Here the raphe is rather small. Here it is a lot larger. And here it is very subtle, right here. So with transesophageal echo, we're able to study even details of the aortic valve, and it is definitely superior to transthoracic echocardiography in detecting congenitally abnormal valves. Which view is this? Clear, this is a short axis view of the aorta. But there's something peculiar on this image. We see that there's a small mobile structure right here, which probably is a part of a atherosclerotic plaque. And this patient is definitely at risk of developing embolism. So the short axis view of the aorta gives us a lot of information. Not only can we see such mobile structures, but we can assess, for example, the degree of atherosclerosis. This is a fairly large fibrous plaque. You still don't have enough? Are you ready for more? Is this a tumor? Definitely there's a mobile structure here on the aortic valve. But what about this, and this? The patient has an aortic valve bioprosthesis, and on top, a vegetation. Those here are the three struts of the bioprosthesis, and here is the vegetation on the prosthetic valve. We usually look at several views to determine whether or not endocarditis is present. So here we have a long axis view as well with the vegetation right here. What is wrong here? Bicaval view, but something looks awkward. SVC, IVC, intraatrial septum, but the position of the intraatrial septum is rather strange. It's that what we call bulging of the IAS towards the right, and the reason is that this patient has mitral valve stenosis. This causes an increase in the left atrial pressure and therefore shoves the intraatrial septum towards the right. The hallmark, as with transthoracic echocardiography, is doming of the anterior leaflet. What about this patient here? 4-chamber view. It's definitely a valve pathology. Definitely the patient has mitral valve prolapse and some form of rupture of the posterior leaflet. You can see parts of the chordal structures prolapsing right into the left atrium. This is the same patient, now with a different view. Long axis view with the prolapsing part of the leaflet right here and a very eccentric mitral regurgitant jet here. Definitely severe MR. So TE is a very good technique if you want to study the morphology and the degree of mitral regurgitation. This is a patient who already received repair of the mitral valve. How can you tell? Well, he has an annuloplasty ring in place. Those little bright echoes are I would say, the transection of the annuloplasty ring. And inside we have the mitral valve. From a morphological point of view, it looks okay. But if you look at color Doppler, we see that there is a jet between the LVOT and the left atrium outside of the ring. So there is a dehiscence here and actually a perforation of the intervalvular fibrosa. Fortunately, this patient was diagnosed early and the patient received a redo procedure, and after the redo procedure, as you can now see, regurgitation is gone. This was before and this is now after. A beautiful way of guiding the procedure and of diagnosing the problem. A very spectacular echocardiogram in a patient with atrial fibrillation and with stroke. Why does the patient have stroke? I think this is pretty much a no-brainer. If you take a look at the left atrium, it's full of clots. This is an organized thrombus right here. This is the left atrial appendage, and there's probably even some clotting here. On top, we see that there is spontaneous contrast. This patient also had a mitral valve bioprosthesis in place, and all this together with poor left ventricular function increased the risk of thrombus formation. But spontaneous contrast is not only present or cannot only be present in the left atrium, but even in the aorta. A patient who had long-standing arterial hypertension, and this is the short axis view of the aorta. You can even see the blood flow. In addition, we see that there is spontaneous contrast here. This is recorded during a cath study in the cath lab. So what you see here is the catheter going up the descending aorta. And sometimes we find rather surprising findings, as this huge thrombus coming from the SVC in a patient who developed pulmonary embolism. No wonder why the patient has pulmonary embolism. Obviously, parts of this thrombus have dislodged. Now, the reason that this patient had the thrombus was that he had a central line catheter in place and that he had a coagulation disorder. So, to summarize all of this, what are some of the key points that you should know? First, watch out for pseudotumors so that you don't mistake them for pathologies. Second, use transgastric short axis view to study left ventricular function and regional wall motion abnormalities. Don't forget that we should look outside the heart to detect, for example, things as pleural effusions. TE is great to detect bicuspid valves, and TE is also very, very good to look at the mitral valve to determine whether or not mitral regurgitation is severe or not and what the problem is. Furthermore, spontaneous echocontrast is a problem, both in the left atrium or in the aorta or anywhere you see it. And then finally, don't forget that embolism can occur if you have plaques in the aorta or anywhere else. So as you see, transesophageal echocardiography is not much different from transthoracic echo. Both have the same pathologies. And my take is, if you're an anesthesiologist, also learn transthoracic echo. And if you're a normal cardiologist or internist, also learn TE, or at least know what you can do with it. So they both belong together.